Now I would like to request a Professor of Eminence and Advisor Academics, Professor K.V. Somasundaram sir, the senior most member of our esteemed university, who has excelled in all aspects of academics, clinicals, and research. Sir has been an irreplaceable pillar who have been traveled throughout the developmental journey of Srihar under every circumstance occurred. I request him to deliver the inaugural address. Sir, please.
Afternoon, quite an exciting program. I've lived long enough to see so many things happening here. First thing I've realized, what was known as a health service or health care thing is now known as an industry. There are so many people involved, organizations, specialists, each one competing with another. At the same time, this is one place where people have realized it is a team service. Ultimately, the beneficiary is the human being. For the care of his health, the entire lot of people are working as a single team. Very unique. In any other industry, you will find it will be competition, good or bad. But here is one such place where the competition is only to do a little better than the other fellow. The service basically remains a service. Even though people call it as an industry, it remains basically a human service. Why I'm saying that? Because I've seen so many specialties. No longer is the doctor the important man in health service. In fact, today it is called administered service, managed healthcare. Any professional by himself cannot, shall not, will not be able to do what needs to be done. You need a separate administrator to coordinate the activities of all these specialties. Just to mention this is your specialty. Probably 10, 12 years before, the general public would not have even heard the word occupational therapy. Therapy itself is something new. People are used to many other things, but therapy as a specialist was thing. And once people like me who have been in the field started seeing occupational therapists at work, I can tell you it is sheer magic. What I can talk theory, what I can tell the patient, go home and do, I've seen it happening with my own eyes. And it is a very structured program. It's not that somebody comes, talks something and does run away. It's a beautifully structured program with often predictable results. If in some places the results are unpredictable or not as per expectations, invariably the biology is wrong or the damage has gone too far. There are so many complications, human system, as your own specialty shows, starting from muscle, nerve, brain, so many structures involved. And mind you, it's not just one nervous system, for example. People do not even know how many cells are there in a human being. Some people say 20 billion, some people say 10 billion. Anyway, it is in billions. And those billion cells don't work like you expect. Ultimate product is one, but they all work differently. So much so, today people are saying the male brain functions differently from the female brain. Basically, it is brain, motor functions, and cerebral, all those are there. But there are subtle differences between a male brain and a female brain. More so, a right half of the brain and a left half of the brain. If there is a damage in speech area, for example, the surrounding area or some other area, can it take over the function? I'm just giving an example. In a right-handed individual, that you must be doing to make his left hand work as efficiently as the right hand doing. You people are doing it like a magic. The whole thing to me looks like a surprise. And most important is today's program. The program only emphasizes this is a dynamic, vibrant specialty. What you read yesterday is already 1 day old. There is so much of information going around. That information must be collected, culled, presented as a knowledge. Just as I said, healthcare is a management. Today, knowledge is also to be managed. You have to acquire, give it to others, make it spread, innovate, etc., etc. There is so much to be known, so much to be shared, and having shared must put into practice. That is the beauty of your specialty. Acquiring knowledge is only one half. Making it work on suffering human beings. That's why I said, though it's becoming too big and is like an industry, it is still a service to a suffering human being. You are all involved in that to one big team. It's not like Commonwealth Games or a chess Olympiad. It is a health industry which is functioning every day. Every day is an important day for us. Today, little extra care, extra special for you. You are all in for a big academic treat. Wish you good luck. Thank you.
Thank you so much, sir. Thank you for your precise and all this inputs. Definitely will take in our account, sir. Thank you so much. So, on briefing about the today's session, occupational therapy has its own origin of in the field of psychiatry and mental health, and we take this as a positive note that occupational therapy in mental health is the first webinar organized by our Sri Ramachandra Faculty of Occupational Therapy after becoming an independent constituent faculty of Sri Ramachandra University. On signifying the role of occupational therapy in psychiatry and mental health, it is said that occupational therapists engage people in meaningful occupations by making an attempt to keep their productivity, attentiveness, mental health using various techniques of practice. Occupational therapists are specialized in treatment protocols in pre-occasional, occasional, and recreational aspects. It focuses on engaging people into places suitable requirements like halfway homes, shelter workshops, daycare centers, psychiatric rehabilitation units, and diagnostic groups, for example, Alcohol Anonymous groups. And I'm glad to introduce our guest speaker, Dr.Nidhi.N.Dave, who is an assistant professor in KMCH College of Occupational Therapy, has completed a bachelor's degree in KMCH and completed a master's in advanced occupational therapy in mental health in KMCH College of Occupational Therapy. And she also completed her MSc in applied psychology from Bharatya University. And Dr. Nidhi.N.Dave is a life member of Tamil Nadu All India Occupational Therapists Association and All India Occupational Therapist Association as well. She is also a member of professional body of World Federation of Occupational Therapy. She has won gold medal in undergraduate and postgraduate paper presentation in IOTA national conferences and won Vijay Supply Award for the presentation. She is also a recipient of Best Outgoing Student Award from Tamil Nadu All India Occupational Therapists Association, and her clinical interest is on pediatric and adult psychiatric and psychological units, developmental pediatrics, and rehabilitation. Now I hand over the session to Dr. Nidhi.N.Dave, and ma'am, it's all yours now.
Many thanks for the wonderful introduction. I begin by invoking Almighty's blessings, and I am very thankful to the Faculty of Occupational Therapy, Dr. Raghuram sir, for inviting me as a guest speaker, and I feel honored and privileged that I am the first speaker for the Faculty of Occupational Therapy at Sri Ramachandra Institute of Higher Education and Research. Many thanks for the same. It would not have been possible for me to speak before all of you had it not been for the support and guidance that I have been receiving from my mother institution, that is KMCH. Many thanks to KMCH, who has made me capable enough to stand here, and many thanks to my teachers also for the same. Dr. Somasundaram's speech at the beginning was very inspirational. His ideas have evolved based on his experience. He spoke to us about administered service, managed healthcare, and these are ideas which require constant updation from our side. Sir also spoke about the importance of lifelong learning, and I think that is a lesson that all of us as professionals should take, and we should be acquiring knowledge from every possible source and also take proactive efforts in implementing or applying what we have learned for the ultimate benefit of our patients. As occupational therapists, we work as a part of multidisciplinary teams, holistic teams, to ensure that the ultimate recipient of our service, that is our clients or our patients, are benefited the most. So through webinars like this, through continuing educational programs, we are able to update our knowledge, to gain newer perspectives, and we are also able to use the knowledge that we have gained for our patients. Sir also mentioned about the lack of awareness amongst the general public with regards to what therapy is. So as sir has rightly said, people are not very aware of what exactly is therapy, leave alone occupational therapy. Of course, there are confusions with other professions as to what our unique role is, and I think I will be able to shed some light from my perspective as to what is the role of occupational therapy in mental health. To get started with, I will start sharing my screen. Sir, is my screen visible?
Yes, ma'am, your screens are visible and you're audible. You can continue.
Thank you for confirming that. So when we hear the word occupational therapy, what first comes to our mind is the word occupation. In common language, what we understand by the word occupation is a profession that people do. But when we want to understand it from the perspective of occupational therapy, occupation is much beyond just a person's profession. It involves everything and anything that a person does to occupy their time, and it should be meaningful, productive, and contributing ultimately to their social fabric. These are some words which we commonly come across: strength, leisure, health, emotional development, quality of life, day to day activities, etc. So let us understand it from a deeper perspective. Occupational therapy, as such, is a client centered profession which is primarily concerned with the promotion of health and well being through the use of occupations and activities. Our primary goal is to enable people to enjoy life to the fullest by enabling them to participate in what is meaningful to them. It enables them to participate in activities of daily life. It enables participation in work or occupations, as we say, productive occupations. It enables participation in leisure pursuits so that a holistic balance is achieved in an individual's day-to-day life. Now, how do we achieve these outcomes? It is by working with people and with communities so that we enhance the ability of individuals to engage in occupations that they want to do, they need to do, or they are expected to do. We do this by modifying either the occupation or the environment in order to support occupational engagement. What I mean by occupational engagement goes beyond the term participation. When I talk about engagement, what I mean is the ability to be a part of something which is of importance to an individual. Let me try to explain this by giving an example. Let us take the example of a child who is bound to the wheelchair because of some kind of disability. Now, that child may not be able to participate actively in running a marathon, but still, that child can be engaged in the occupation of running a marathon by means of enabling the parent or the caregiver of the child in order to engage them by using a wheelchair or by using some other means of mobility so that the child is able to engage in that occupation of participating in a marathon. So occupational therapy goes much beyond facilitation of participation, and it goes into supporting occupational engagement. We follow a holistic perspective where the focus is on adapting the environment or the task, and the person is the integral part of the therapy team. Why I say the word holistic is because it looks at a whole person view. Our domains of concern are not just limited to the physical aspects, the cognitive aspects, or the emotional aspects of a person. We go beyond that and look into what constitutes the core of a person. What is it that is enabling participation? What is it that is limiting participation? With our focus being adapting the environment or the task, rather than making a person fit into doing something. You are disabled, so you do this kind of job, is something which would be traditionally thought of. But from an OT perspective, our focus is on adapting the job or adapting the task and enabling the environment so that the person is able to engage in occupational participation. The person is an integral part of the therapy team. As a profession which follows a client-centered perspective, the person is at the center, or he is the ultimate recipient of our services, and our focus is on the client's priorities. Rather than we dictating as therapists what the client should be doing, our focus is on understanding what are the client's priorities, what is important to the client, and tailoring our approaches and our interventions in order to facilitate the best outcomes for our client. It is an evidence-based practice deeply rooted in science. Why I say deeply rooted in science is because the profession of occupational therapy faced a major dilemma at the turn of the century. At that point of time, there came something called as occupational science. Occupational science formed the base, the theoretical base, which supports the philosophy of occupational therapy and which supports our ultimate viewpoint that occupations themselves are meaningful and healing in nature. As occupational therapists, our areas of practice range from a diverse settings, that is right from the neonate or the child who is born premature and in the neonatal ICU to the person on the deathbed who may be at the receiving end of geriatric or palliative care. So our areas of practice span from neonatal health, early intervention, working with children, pediatrics and child psychiatry, working with adults who may have a variety of diagnoses or disabilities, such as neurological problems, orthopedic problems, psychiatric or mental health problems, to people with chronic illnesses and disabilities, to people of the older age group requiring supporting living facilities. So this is a holistic profession whose area of practice spans across the lifespan, from a child to a person of an advanced age till the end of life. Moving on to today's topic, we are going to be discussing about occupational therapy in mental health. Let us start by understanding what is mental health. When we say that a person has good mental health, it means that the person is able to realize their potential. He or she is able to cope up with the daily life challenges. He or she is able to productively work and contribute to the community. Statistical figures indicate that 1 out of 4 people globally are affected by mental health problems or neurological problems in their life. And it is estimated that 2/3 of people with mental health problems never seek help from professionals, and they have many comorbidities. Now, this again is a major problem which our country especially is facing. There is a lot of stigma related to mental health. People do not want to proactively take steps for their mental health conditions, primarily because of the stigmatic and the social factors. So as therapists here, our role is to create awareness and to strive to destigmatize the stigma that has clouded the area of mental health. There is high prevalence of mental health problems which will significantly affect all areas of life. Depending upon the age of the person, it may be either school participation, it may be participation in work, it may be participation in family life, involving in leisure. inclusion, etc. Ultimately, because of difficulties in participation in all of these areas, the individual ceases to be an active contributor to the socio-economic fabric of the family and ultimately of the community. So here again, it is our role as professionals to aim for destigmatization and awareness among the general public. Mental illness is not one term, and mental health is not a separate entity, and both are not watertight compartments. It is rather a spectrum, with mental illness on one end to flourishing with mental health on the other end. So it can the continuum of mental health can range from either acute mental illness or mental health challenges at one end of the spectrum to mentally healthy individuals flourishing in their lives at the other end. Mental health is not merely the absence of a mental illness, but the presence of all positive characteristics, including positive affect, psychological and social functioning ability, and the ability to adapt and change with the challenges thrown by everyday life. People who are mentally healthy, even with the presence of a mental illness, can function better in their everyday lives and engage in all activities which are required to maintain their health. That is possible only when there are appropriate measures both at the individual and at the community level, so that the persons with mental illnesses are also able to function in their day-to-day life and contribute productively to their selves and to the society. Now, because there is a dynamic nature of mental health and mental ill health in an individual's life, we as occupational therapists should tune into this and should address all of the health needs of an individual in all practice settings. So, as occupational therapists, even if we do not specialize specifically in mental health, it is very important to have an understanding of mental health, mental ill health, psychology, psychiatry. All of these subjects are beautifully interwoven in our curriculum, and they are executed in our curriculum so that we as professionals have an understanding of all of these areas and we are able to apply the learned concepts into our practice. Now, it is not necessary that mental health problems can arise only when there are psychiatric diagnoses. Even an individual without a psychiatric diagnosis, let's say an individual has met with a stroke and he or she has a disability, there are mental health implications that the person will ultimately face, such as not being able to cope up with the new challenges as to how to maneuver in an area with just one side of their body functioning. The psychological coping that comes when a new disability diagnosis or when a person faces a new disability. So, such are the areas of practice which we as occupational therapists involve and engage ourselves in. Our profession has a rich history of promoting mental health in all areas of practice through the use of meaningful and enjoyable occupations. Ultimately, with a client-centered focus, our aim is to focus on the areas of life that are meaningful to the client and which ultimately enable him to enjoy his or her life. The aim of OT services in mental health is to help all individuals to develop and maintain positive mental health, to prevent the occurrence of mental ill health and recovery from mental health challenges in order to live fulfilling and productive lives. Occupational therapists support individuals with mental health conditions for them to engage and participate in roles and activities that they do and that they find meaningful. The focus is on recovery, which can be worked on a one-to-one basis or it can be worked on a group setting with a variety of techniques such as coping strategies, social skills, use of SI therapy, etc. We also recognize that everyday occupational engagement has a definite influence on an individual's mental and physical health. Imagine a day where you would not do anything. I'm sure it's not possible for anybody to sit idle for the whole day without engaging in any kind of occupation. So, as OTs, we recognize that each and every activity or each and every task that we do has a direct influence on our mental and physical health. OTs also believe that occupational performance, organization, choice, and satisfaction are influenced by the relationship that individuals have with their environment, with their society, with their culture. Occupational therapists approach mental health with this particular unique perspective, which considers a person's needs within the context of their family and of their community. As it was mentioned previously, it is not a one-man army that leads the show today. We have moved from that perspective or from that model of care where there was one head of the team supervising and directing the other members of the team. Rather, it is a holistic, collaborative approach in which there are multiple people. The ultimate stakeholder of this is the individual and his or her family. With them, we have support providers, doctors, nurses, teachers, aides, counselors, therapists, social workers, you name them, and they're a part of the team. So this team together comes and ultimately works for the benefit of the patient. This type of collaborative approach will allow everyone to work together rather than having competition. It allows everybody to be a part of a team, to contribute their own unique skills, to contribute with their own unique knowledge, and to reach the specific goal. That is to improve the individual's quality of life, engagement and enjoyment in life, and by identifying and meeting appropriate behavioral and skill needs. We collaborate with many professionals to help individuals on their road to recovery. While our role may overlap sometimes and there might be role confusions as a part of professional practice, we have a unique theoretical and clinical contribution in the recovery and treatment team, and thus OT should be and is considered as a vital part of a comprehensive and integrated treatment program. As occupational therapists, we work in a variety of mental health setups, which can be government hospitals, private hospitals, psychiatric institutions, family therapy units, therapeutic communities or milieus, halfway homes, geriatric units, sheltered workshops, rehabilitation setups, daycare centers, forensic units. In almost all areas where we see clients who have mental issues or mental health issues, occupational therapists do have a unique role to play and address the needs of their clients. What do we do as OTs? It extends just beyond the role of occupations. With the ultimate goal of enabling occupations, we work by doing cognitive assessments, functional assessments, sensory profiling, goal setting, development of skills, training and strategies, use of activity-based social skill interventions. These are some of the areas which we work with our clients as the central focus. By doing cognitive assessments, we identify what are the cognitive barriers to activities, such as taking medication. A person who is forgetful or has memory issues may not take their medication on time. Because of difficulties in their executive functioning, they may not be able to organize their daily living activities. Because of the limited cognitive capability, they may not be able to participate in certain types of activities which require sustained cognitive effort. So by understanding what is the level of the cognitive aspects of the client, by doing a thorough cognitive assessment, we as occupational therapists can strategize and formulate definitive cognitive therapy strategies which we can implement based on the level of the client's functioning. Moving on to the functional assessment, we identify what motivates successful functional performance. By doing something as basic as activity analysis and task analysis, we are able to break down complex activities and tasks into minor portions which can be easily trained and easily performed by individuals with adequate support and guidance. While we do sensory profiling, which is a very unique aspect of OT, we determine what are the sensory processing patterns and what can be the intervention strategies that can be used to match the client's needs and the available environment. For goal setting and skill development, we use a variety of assessments and approaches, and it is based on activities which are meaningful to the client. We also indulge in strategy training where we engage the client in repeatedly practicing activities as a part of their cognitive remediation, as a part of their functional remediation, and allowing them to practice those activities using a well-built strategy helps them to learn to involve themselves in each of the activities which they find meaningful. By use of activity-based social skill interventions, which can be individual or group interventions, we improve their social behaviors and also aim to reduce behaviors which can be identified as problematic or disruptive behaviors. We also help individuals to get back into their previously valued roles or to get into new roles by doing a variety of assessments. We identify what are the goals, what is the individual's capacity, what are the potential enabling factors, and what are the potential barriers. After identifying what is meaningful and what can be a goal, we set SMART goals and work on the skill development in order to achieve those goals. Next, we promote participation in those activities and those goals which are meaningful for the client by engaging them in learning so that they are able to participate in the valued roles. We also improve performance by not just working on the client, but also by modifying the task and the environment. So we use a lot of compensatory strategies. We suggest a lot of accommodations which can be based on the needs of the individual. We use activity analysis to break down skills so that they can be gradually mastered. Now, today I'm going to talk about occupational therapy in mental health. So it's not going to be just enough if you're going to listen to one talk, and we cannot say we are knowing everything about occupational therapy in mental health. We break down the different components of occupational therapy in mental health into different sessions, and we learn in depth about each of the sessions. Similarly, from an activity analysis perspective, we consider the activity as a whole, break it down into multiple components, and work on each of the components so that the client masters each component in order that he or she can perform it satisfactorily to their level. Our domains of concern or areas of concern from mental health and OT perspective are limited not just to motor, sensory, cognitive, self-care, interpersonal, intrapersonal, productivity, and leisure. It goes beyond all of this. So it is an amalgamation or a combination of all of these factors put together, which constitute the whole person. So from a whole person perspective, we break down these into different segments, such as the motor components, the sensory components, the cognitive components, the self-care skills, interpersonal and intrapersonal skills, participation in work, participation in ADL, participation in leisure, etc. Now, each of these components has a specific role for an occupational therapist to work upon. For example, a person with reduced psychomotor activity will have slowness in performance. So from an OT perspective, what do? We make sure that the person has enough time so that he or she is able to complete the activity in spite of reduced psychomotor activity or slow speed of performance. From a sensory perspective, an individual can face hallucinations, maybe auditory, maybe visual, maybe somatic. There can be delusional thoughts, which may also have somatic concerns. So from an SI perspective, we work on these hallucinations, delusions, other areas of sensory integration dysfunction, and provide SI therapy services. From a cognitive perspective, it is an entire spectrum of issues which can arise in a person's cognitive faculty. Examples being attention, concentration, decision making, problem solving, and these can arise out of a variety of conditions. So based on the needs of the client and based on the cognitive level of the client, we structure or modify the activities so that the client is able to perform the activities based on their cognitive level. Next, we have the areas of performance being self-care, productivity, and leisure. So ultimately, our goal is to enable participation in these areas of performance by modifying the environment and the task so that maximum participation and engagement can be achieved. We also work on interpersonal and intrapersonal components such as socialization, communication, being a productive member of the society, working on an individual's self concept, self esteem, feelings, etc. So, by working on each of these individual components, we are able to ultimately help the client in order to facilitate a better life. In OT, we do not work without a guiding light. So we look at it from a historical perspective. OT has its roots in mental health. We came from the arts and crafts movements, then came the industrial revolution. So at that point of time, occupational therapists engaged clients in doing craft activities, in doing art activities. Then came the era of industrial rehabilitation where the focus shifted to ergonomics. Then from the world wars, the focus was more on rehabilitation. So, in order to prove our space or in order to justify what we were doing was just beyond activities or beyond art and craft, we had the occupational science perspective coming in. So, with science as a base, we always have an informed and evidence based approach. So, in occupational therapy, theories, models, frames of reference, and approaches help us or guide us in implementing the treatment programs. From a mental health perspective, we have various frames of reference, which can be cognitive behavioral, acquisitional, behavioral, psychoanalytical, occupational behavior frame of reference, MOHO, developmental groups and developmental approach, the SI approach, the cognitive disability frame of reference. So these are the broad frames of reference or the broad frameworks within which we work, and these are the frames which guide our practice so that we are able to deliver the outcomes for our clients. Now, these frames of references also stemmed from certain theories such as the humanistic theory, the client-centered theory, the cognitive theoretical base, the use of group therapy, the use of anxiety management approaches from the other disciplines, use of newer techniques such as reminiscence therapy, the importance of physical activity as a part of our day-to-day lives, implementing reality orientation, the use of environmental adaptation to enable performance, and the use of assistive technology. Next, I'll be talking about the use of group therapy in occupational therapy. So in mental health, group therapy is a very common practice, irrespective of where we work in. It can be psychiatric rehabilitation units, it can be vocational rehabilitation units, it can be halfway homes, it can be forensic units. So the groups can be primarily divided into groups such as self-care group or ADL groups, creative activity groups, sensory therapy groups, skill training groups such as social skill training groups, support groups such as stress management groups, coping skill groups, etc. So as a part of group therapy, what we do is we identify members of the group who will ultimately benefit by being a part of the group, with the occupational therapist more as a facilitator rather than a leader in the group. The OTs work with the clients in a part of a group. Now, Yalom, as he says, groups have many therapeutic benefits. So by enabling participation in group therapy for our clients, what we are doing is we are instilling hope in them that they are not alone. There are other individuals like them. They can develop the feeling of empathy for the other individual who has the similar suffering as that they are suffering. So by enabling participation in groups, we are not just training them in different skills, but rather giving them a perspective of our lives, or rather giving them a perspective as to how to go about lives by being a part of the society. We know that we cannot exist individually in the society, but we are a part of various social groups, whether we voluntarily are a part of it or involuntarily we are part of it. So group therapy in OT has a very unique place where we enable skill training as well as real life transfer of those skills into real life settings. Moving on to the different conditions which we can see as occupational therapists. Across mental health conditions, we have the most severe or the most debilitating condition, that is schizophrenia, psychotic disorders. Then we have the mood disorders, we have the anxiety disorders such as anxiety, panic, phobia, OCD. We have the somatoform disorders, the psychosomatic illnesses. We have dissociative and factitious disorders, sleep related disorders, eating disorders, substance abuse related disorders. In child psychiatric conditions, we have disorders such as autism spectrum disorder, learning disorders, attention deficit and hyperactivity disorder. So, what we essentially understand from this is our work or our area of practice is not just confined to one particular group of individuals, but rather it spans across individuals with different levels of functioning, which may be because of different types of illnesses or because of different types of disabilities. We'll start with looking at what schizophrenia is. So, schizophrenia is a very chronic and debilitating neuropsychiatric condition. There are difficulties in almost all major aspects of life, such as thinking, perception, emotions, language, behavior. Because of these difficulties, there are deficits in specific areas such as being able to pay attention, being able to concentrate, being able to memorize information and retain it, etc. There are also very disturbing and frightening experiences such as hallucinations, such as hearing voices or seeing things, which have a significant impact on the individual's life. And because of the nature of illness, this is something which the individual may not realize as an illness and can rather be frightened by what the individual is going through. Adding on to that is the stigma that is surrounding all mental health conditions, with the disease on one end and the stigma on another end. What ultimately happens is there is a delay in seeking treatment. Because of the delay in seeking treatment, the disease can progress over a long course, and the individual experiences significant difficulties in all areas of their day-to-day life. So, because of all of these areas, if it is left untreated, then it can lead to major complications such as suicide in almost 25% of the individuals. Nearly 90% of the individuals who are left untreated live in our country, that is India. There are an estimated 4 million people who are living with schizophrenia in India. And the direct impact of this is on their family members as well. It is a severe form of mental illness, not affecting just the individual, but affecting everybody surrounding him or her. The extent of the illness is so much that 10 out of 1,000 people in our country can have a possible diagnosis of schizophrenia. So it is important that we as professionals recognize the early signs and symptoms of this illness and catch, or rather educate the individuals to seek help as soon as they find such disturbances in their day-to-day life. Our unique role here is to develop a supporting relationship with the patients and the caregiver. The needs of the patient, what are the needs of the patient's family or the caregivers, and provide them with the right information. When we provide them with the right information, they are in a better informed space, or they have the adequate knowledge to help their loved ones or to help their family members. Because of the equipped knowledge that they have, they are enabling a better quality of life for themselves and for the individuals who are suffering. The next most important aspect is the use of purposeful activities. So as OTs, purposeful activities are something which we always talk about, but more so in the case of schizophrenia, where we actively involve or engage a person in occupational engagement, and that forms the crux of our OT intervention. The short-term goals of our therapy will be on evaluating what are the strengths, what are the weaknesses, what are the skills that the individual has, and what are the impairments that the individual is currently facing. No actual rehabilitation takes place in a short-term setting, but the needs of the patient are identified and we direct them in the right course so that a long-term plan can be established and adequate supportive measures can be implemented. Now, each of these steps has a unique point here. We need to develop a supporting relationship. Why do we need to do that? As therapists, what I have observed in my clinical practice is we spend the most amount of time with our patients and their caregivers. As a result of spending more time, the patient develops or establishes a comfortable rapport with the therapist. Similarly, the caregivers feel free to ask their doubts and questions to us, which they may not necessarily ask to the attending psychiatrist or the physician. So it is very important and imperative that we develop a supportive relationship with the patients and caregivers, irrespective of what our area of practice is. We should work on using ourselves as a therapeutic medium. We have a unique approach in occupational therapy known as therapeutic use of self, where we use our attitudes, our personality in order to guide the treatment progress. There is also something called the intentional relationship model, where the therapist works upon his or her own capabilities and shapes his or her own way of communication in such a way that it is therapeutic and meaningful for the client and their families. We also spoke about taking into account the needs of the patient, family, or caregivers. So, caregiver burden is one topic which goes very unaddressed in our country. There are, in our cultural context, we see that family members, without batting an eyelid or without making a sad face, will take care of the person who is having an illness or a disability. But what happens because of the responsibility that comes with taking care of an individual with an illness or a disability is the effect on the mental health and the physical health of the caregiver. So we as OTs are in a unique position to understand how much of effort the caregiver is putting in, how much of impact it is having on their life of the caregiver. So because we understand, because we have identified that the caregiver is going through certain stresses or certain life changing issues in as a part of their caregiver role, we should take into account all of these. And what we can do is one simple thing such as supporting the caregiver. That can be through one-on-one interaction, that can be through groups of support caregiving, etc. Next is the role of purposeful activities, in which we involve the individual in doing purpose activities which they find meaningful and relevant. Not just giving them some kind of random activity which may not be meaningful to them, but rather identifying what holds meaning to them and engaging them in those particular activities. We also need to understand not just what are the deficits of the client, but what are all the strengths, what are all the capabilities, what are all the skills that the individual has. So as a part of a strengths based approach, we consider what are all the positive aspects of the clients, what are all the aspects which will help the client or enable the client, and we work on improving those strengths along with working on teaching new skills and working on the areas which need modification. We work on the areas of strengths, we strengthen those areas and help them to become masters in the areas that they are already capable of. So by doing this, it is more of an enablement process. Rather than looking at the disabilities that the client has, we are taking into account what are the capabilities of a client and strengthening them. Long term, we work on training them in social skills, independent living skills, both basic and advanced, that is ADL and IADL skills, psycho-educating the family, working on issues such as expressed emotions, management of medication, management of symptoms, assertive clinical case management by being a part of the community-based setting where we work as health professionals responsible for bringing about changes in the community, supporting their housing and employment by working along with psychiatric social workers, rehabilitation workers, working on improving their tolerance skills, working on improving their dressing, grooming, and self-care skills, working on social interaction, communication, time management, IADL skills, budgeting, money management, and vocational rehabilitation. Moving on to the next class of disorders, we have the mood disorders. So the mood disorders are also a spectrum, just as we saw at the beginning of the presentation, that mental health and mental ill health are a spectrum. Mood disorders can also range from a spectrum of severe depression at one end to mania at the other end. We have different technical diagnoses based on various criteria such as the ICD and the DSM, such as depressive disorders, cyclothymic disorders, recurrent depressive disorder, BPAD, etc. In the mood disorders, our goals are to formulate the short-term and long-term goals, to improve their mood, to involve them in meaningful activities, to improve their performance of aerial activities, to reduce the symptoms of anxiety and restlessness, to work on improving their physical strength, and to work on improving their social interaction. The next is the obsessive compulsive, the anxiety, and the phobic disorders. So this is one cluster of disorders together, which can also include post-traumatic stress disorders, phobias, panic disorders, etc. In OCD, our specific role is to provide the client with purposeful activities which can be a distraction from their repeated obsessions and compulsions. Now, obsessions are the repeated thoughts that the client has about a particularly overvalued idea or a feeling, and the compulsions are said to be actions that the client performs in order to gratify the obsessions that the client is facing. So by providing them with purposeful activities, we help them in getting unstuck or getting distracted from the obsessions that they are having. When they are getting stuck, they often get angry. So by distracting them, we quickly involve them in something which is meaningful to them and which they are enjoying. Occupational therapists work by grading activities, pacing the activities, and modifying and adapting the activities so that it is possible for the client to participate in those. So we break down the task into specific small skills and ask the patient to do a small part of the task. When there is satisfaction or that task is achieved completely without any kind of mental anxiety or problem, the therapist may ask the patient to move on to the next part of the activity. For example, we can ask them to write about themselves. This can be given as an unstructured activity or a semi-structured activity. Now we break it down into different parts where we ask them to write about what are your positive aspects and what are your negative aspects. So by writing what are all the positive aspects, the patient realizes, okay, this is all good about me. These are all my skills. These are all the areas of capability which I have within myself. Next, we ask the patient to write about things which they may feel is negative about them or areas which they may feel they need to improve. So while doing this, what we do is we ask them to write it down, and we are passive observers, but careful observers, where we identify what is it that is making the patient anxious, what is it that is going on at a thought processing level in the client's mind. So by doing such a complex task or an activity in such a manner, we are able to identify what is good about the client, and we are also able to identify what are the areas that the client needs to actively work upon. We can also ask them to perform their activities which are purposeful to them. If they are familiar with it, they may enjoy the activities and they gain intrinsic motivation from the activities. But if they're not familiar with those activities, and if there is a lot of pressure that the activity should be performed, then the therapist works with the client in teaching them specific strategies to perform those activities. An important area which we focus upon in most of the anxiety and the mood disorders is the use of relaxation techniques. So there are a variety of relaxation techniques which we implement. We learn those techniques, we implement it for our clients, and at times we also implement it for ourselves in order to achieve balance in our lives. So we can teach our clients about changes in their lifestyle, changes in their thinking patterns, changes in the way they approach a particular situation, etc. We have specific techniques such as yoga, JPMR, the use of breathing exercises, meditation, mindfulness based strategies, etc. So we identify and we expose them to those particular areas or those particular triggers which are actually stimulating or which are actually triggering their obsessions or compulsions. Next, we implement a desensitization program where by means of identifying what are the obsessive thoughts and what are the compulsive behaviors, we are able to make a hierarchy or make a list in a hierarchical manner of what are the obsessions that the client has, what are the compulsions that the client acts upon. Then we start with a low impulse thought and progressively we move towards something which is of moderate level of impulse. As I spoke about it in schizophrenia, it is very important and imperative that a good client-therapist relationship is established because this will form the basis of our therapy process. If the bonding is good, if the rapport is good, the patient will feel very comfortable in sharing what their actual problem is. So when the patient is sharing what their problem is, that is more than half of the work done. Our work involves identifying what are the problems and then coming up with solutions. So by developing or establishing a working rapport, which is a very comfortable one for the therapist and the client, we are in a better position and we are better equipped to identify what are the problem areas and thus ultimately come up with possible solutions. We also implement relaxation techniques for individuals with anxiety. As I mentioned before, yoga, meditation, pranayam, counting to 10, use of diversional activities can be beneficial. Coping strategies. Now, each of us have different coping strategies which we use to cope up with the daily life anxieties that we may face. So, coping strategies can be either positive coping strategies or they can be negative coping strategies. By analyzing or by working with the client actively, the therapist is in a position to identify what are the coping strategies that the client uses most of the time. Are the coping strategies healthy or positive, or are they maladaptive coping strategies? So, if the therapist identifies that the client is using more of maladaptive strategies, then the therapist works with the client in educating the individual that he or she is using such strategies and what can be the long-term impacts of those strategies. Then we teach them what are the positive coping strategies and guide them and help them in improving or implementing those positive strategies in their day-to-day life. We also spoke about systematic desensitization, where we create a hierarchy. So this approach can be used for OCD, for anxiety, etc. Moving on to the somatoform disorders, dissociative disorders, and the psychosomatic illnesses. The somatoform and pain disorders constitute of a subjective experience of many physical symptoms, but there are no organic causes or no identifiable causes. When I talk about psychosomatic disorders, there is an actual physical illness and the psychological factors seem to trigger or contribute to those particular illnesses. So this is a major difference which we need to understand between somatoform disorders and psychosomatic disorders. Somatoform disorders are when there are physical symptoms, but there is no established cause. Whereas in a psychosomatic disorder, an actual illness is present and the mental or the psychological factors seem to contribute to the development and maintenance of that illness. Malingering is when there is a deliberate faking of physical symptoms to avoid unpleasant situations. So there may be primary gains and there may be secondary gains out of malingering. There is also factitious disorder in which there is a deliberate faking of physical illnesses to gain some kind of medical attention, as we see in Munchausen syndrome. There are dissociative disorders which can be classified into depersonalization, derealization, amnesia, DID, or the dissociative identity disorder, previously called multiple personality disorder, etc. So there can be amnesia or memory loss. There can be episodes of derealization and depersonalization where the person feels he or she is not himself or herself. or derealization, where the individual feels that the world around them is not real. There can be identity alteration in dissociative identity disorder, where the client assumes or takes in different personalities and acts upon them. There can be identity confusion as well, where the individual is confused between the multiple identities that he or she holds. So in all of these disorders, as OTs, our role is not just limited to establishing rapport and contributing to the diagnostic evaluation, rather working on the holistic aspect of the client so that he or she is able to function along with the other supportive measures, be it in terms of psychopharmacology, be it in terms of counseling measures. We as OTs work on the functional aspects of the client in spite of their illnesses. Moving on to the eating disorders, broadly we speak about anorexia and bulimia. In anorexia, the client have a definite weight loss, which may be gradual reduction in their weight loss to a sudden weight loss. There can be a relentless pursuit of thinness, or thinness is a very overvalued idea for them. There is a distortion in their body image, and there is an intense fear of weight gain. Anorexia can be of two types, binge eating type and purging type, or restricting type. So in binge eating type, the individual with anorexia will eat or will consume a lot of food, and later they purge it out or vomit it out or excrete it out. The other type of anorexia is restricting type, in which the individual regularly engages in binge eating, and then through self-induced vomiting or through some kind of laxatives, they restrict the amount of calories that are going into their body. Moving into bulimia, it may be the individual may be of normal weight or can be slightly overweight. There are recurrent episodes of binge eating, and there are compensatory behaviors. There is an unusual worry about weight, and there is lack of self-control over the episodes of worry. In the purging type, purging is present where there is self-induced vomiting, there is use of laxatives or other medication. In the non-purging type, the individual will try to lose their weight through fasting or through excessive exercising. So the primary difference that we need to understand over here is the obsessional thinness is present in the anorexia nervosa, whereas in bulimia nervosa, there may be normal weight or there may be even overweight, but there is no pursuit of excessive thinness and there is no significant weight loss. So here we work with the client in identifying what are their eating patterns, how their eating patterns have an impact, or how their eating patterns can cause nutritional issues, how their eating factors or eating patterns can have an impact on their physical health and their mental health. How do we do this? We provide a safe environment for the client to engage in a variety of activities. They experience a lot of negative thoughts towards the food and towards the behavior associated with eating, not to mention the body image issues that they have. So by giving them a multi-sensory experience, they are able to explore the food by means of smelling it, touching it, looking at it, talking about it, laughing it, etc. So in a group setting where there are individuals with a similar diagnosis, they work in a multi-sensory setup and they understand how the negative eating thoughts that they possess can trigger definitive problems, and how these can be replaced by the use of positive sensory experiences. So this would be assisting them in redeveloping or reforming a healthy response to the body image that they desire, and it also assists in creating a balance in terms of their personal lives. So we allow them to internalize the insight which they have gained. It is not enough if we just gain the knowledge. So when there is internalization, only then implementation of that particular knowledge can take place. So we work on their cognitive skills such as decision making, problem solving, setting up goals, tolerating various imperfections, be it in terms of their own imperfections or imperfections of others. We also assist them in developing coping mechanisms, working on their social skills, healthier self-view to improve their occupational performance. We provide them with opportunities to practice and reinforce the healthy roles and routines, and the occupations that are real life occupations, such as meal preparation, grocery shopping, shopping for clothes, money and time management, stress management, introducing clients to newer leisure activities. Now, because they are gradually moving out of their overvalued ideas in relation to the food, they will have more leisure time at hand, and we help them to explore active leisure activities which can facilitate healthier self-being. Next, we have the sleep-wake disorders. That also spans an entire spectrum, which includes insomnia, hypersomnolence, narcolepsy, breathing related disorders, circadian rhythm disorders, non REM disorders, nightmares, REM behavioral disorders, restless leg syndrome, and medication induced sleep disorders. So, here our role is to educate clients and caregivers on the misconceptions or the misinformations that they have with regards to sleep. We also work on conditions that may be precipitating their sleep quality. Because of pain, the individual may not be able to sleep. Because of certain anxieties, the individual may not be able to sleep. So, by working upon those areas which are affecting their sleep, we are addressing the ultimate problem, which is affecting their sleep quality. Then we work on encouraging healthy behaviors such as reduction of smoking, not taking more quantity of caffeine, including a balanced diet as a part of their day-to-day life, exercising regularly, establishing routines, establishing times for sleeping and waking, regulating their time management, working on pain and fatigue, addressing performance deficits because of difficulties in sleep, such as bed mobility or toileting, working on areas of life which are affected because of the diminished sleep quality, teaching them sleep hygiene routines, which are the habits or the routines which they can follow in order to have a better quality of sleep, teaching them certain cognitive behavioral or cognitive restructuring strategies, such as they have to get out of the bedroom or restrict their sleep during the daytime, giving positive self statements regarding their sleep, increasing their coping skills, working on their stress management and time management, also addressing the sensory issues which may contribute to disturbed sleep, teaching them self management or caregiver management as to how to implement healthy sleep routines, modifying the bedroom environment, such as reducing the level of noise, reducing the sensory stimulus that is present in the environment, changing or modifying the bed clothes, changing or modifying the mattresses, and use of technology such as the use of white noise devices which will enable sleep. Next, we have substance abuse, which can be either illegal drugs or the legal substances. What I mean by legal substances are that these substances are not legally banned, although they are toxic or although they are dangerous. These substances are still available, whereas the illegal substances are contraband substances which can have legal implications if an individual is caught with them. So, the illegal drugs can include heroin, LSD, mandrax, cocaine, marijuana, ecstasy, methamphetamine, etc. The legal substances which can be ultimately or very freely obtained will include tobacco, alcohol, the use of certain medications or prescription drugs such as painkillers or sleeping pills. So here what we do is we first identify that an individual is having a substance abuse problem, how that substance abuse problem is establishing a pattern in a client's life, how their routines and roles and how their everyday life activities are structured in a way which surrounds the use of a particular substance of abuse, how the client is being impacted by the use of that particular substance, and educating them on what are the negative effects of that particular substance. Next, we work on establishing more satisfying and meaningful patterns of time use or helping them explore other pursuits which they can use, working on their coping skills, working on their self-discovery where they identify what are their personal triggers, why they are using certain substances as a coping mechanism. Next, we work with the clients and their families in order to identify what are the occupations and the activities which are important for them. That is the identification of what are their roles, what are the responsibilities which come with those roles, and how the use of a particular substance is preventing them from executing those roles. Next, we try to replace what are all the unhealthy activities or all the consumption activities with healthy and meaningful activities. We also help them to plan, initiate, and track their goals to enable participation in other valued activities. Moving on to the child psychiatric conditions, there are a variety of conditions which we have under the umbrella of neurodiversity. So neurodiversity is the term used when an individual has difficulties with organization, memory, concentration, time, direction, perception, listening skills, sequencing, etc. Now, as a functional impact of these difficulties, there may be low self-esteem, the client may feel anxious, there may be feelings of depression or sadness, and there can be a feeling of exclusion as well. At the same time, because of being neurodiverse, we know that there are certain skills that the individual has, the savant skills that the individual has. They can be highly creative, they can be highly original, or even determined to a very high extent. So neurodiversity is a term which we need to understand from an inclusivity perspective. When I talk about inclusivity perspective, I speak about enablement, I speak about advocating for equal rights for all individuals, irrespective of their conditions or irrespective of their disabilities. So neurodivergent individuals also have the same rights as neurotypical individuals in spite of the differences or in spite of the challenges that they are facing. So the various conditions which we can see clinically as a part of the neurodiversity umbrella are dyscalculia, that is difficulty in mathematics, dyslexia, that is difficulty in reading and writing, dysgraphia, which comes along with dyslexia. There is lack of concentration or distractibility, which we see commonly in conditions like ADHD and ASD. In ASD, we also have the different disorders such as Rett syndrome, Asperger's syndrome. Although the terminology may be dated, they all fall under the spectrum of ASD, where there are problems in social communication, there are obsessional interests, and there are differences in the way they imagine and think. There is Tourette's syndrome, where there may be physical and verbal tics. There is dyspraxia or developmental coordination disorder, in which there is difficulty with planning the movements or the motor patterns. There are difficulties with coordination, and because of that, there are functional impacts in their day-to-day life. There are also issues with spatial awareness, muscle tone, planning out the movements, and executing them. So comprehensively, rather than speaking about each of these diagnoses separately, I would like to speak about it comprehensively from an OT perspective. We focus on a child environment task balance, which is present at the center or at the core of this model. We work on all of these areas, such as the environment, the task, demand, etc., for them to successfully participate in all of the different areas of occupation. Now, the aspect of the child which we must take into consideration while we work with the neurodiverse population is, what is the neurological level of the child? What is the psychological level of the child? What are all the behavioral strengths and what are all the behavioral challenges that the child is having? From a neurological perspective, are there any genetic components involved? Is there any kind of genetic involvement, such as we see in Down syndrome? Is there the role of the prefrontal lobe, which is causing their behavior? Is there the role of the caudate nucleus? Are there any kind of neurotransmitter imbalances? Is there any difficulty in sensory modulation? Is there any hypo or hyperarousal? So these are all neurological aspects which we must take into consideration. The psychological aspects which will result because of the neurodiversity will include the level of attention, the impulse control, how they behave, difficulty in regulating behaviors, difficulty in executing executive functional skills, difficulty in motor control, etc. The behavioral implications can be either inattentiveness or hyperactivity. There can also be impulsivity, as we see in ADHD. There can be associated behavioral issues such as reduced social skills or dysfunctional social behavior. There can be emotional issues, etc. So while we want to adopt this approach, or while we try to implement this in our practice settings, it is imperative that there should be family support and community support. What usually happens with any kind of client is they come to us for a brief period or of, let's say, an hour or two of therapy. Beyond the hours of therapy, what we need to address really as occupational therapists is what happens to the client beyond the therapy hours. What is happening to the rest of the 22 hours that the client is facing? Let's say the client comes to you for 2 hours of therapy. So the rest of the 22 hours, what are all the challenges that the client is facing? What are all the simplifications, or what are all the interventions that can be implemented by the parents, by the family, at the community level? So if we are able to design our plan in such a way so as to address all of these areas, that is the therapist support, the family support, parents, caregivers, grandparents, siblings, the school support, or any kind of educational intervention that the client may be going, it may be special education, it may be inclusive schooling, what are all the community resources available. So if we are able to make a balanced fit out of all of these approaches, or out of all of these resources that are available, then we are enabling the child for successful participation in all of the occupations such as ADL, IADL, education, work, play, leisure, and social participation. Specifically for autism, we have interventions which are very unique to our profession, that is the SI therapy, developmental motor activities, play activities, and by engaging the client in all of, by engaging the child in all of these activities, we work on improving all of their skills which are necessary for participation. So in SI therapy, because of the various sensory issues that the clients may have, there may be dysfunctional behaviors as well. So we as OTs use activities so that the child is able to register, modulate, and act meaningfully and productively based on the sensory input. Our main goal, or our ultimate goal of using SI therapy here, will be to develop adaptive capability and to enable successful participation. So because of the lack of inner drive that these children might possibly have, the therapist has to work extra, or the therapist has to put in more effort so that the child can balance himself or herself, and there can be self-regulation and motor planning. We have different strategies which we will work upon so that there is a regulation in their arousal level, there is a flexibility in their mental functioning, they have the ability to attend and reduce the distractibility that is present, decrease the anxiety, decrease the problematic behaviors, and decrease the stereotypic behaviors. Next, we have something called behavioral therapy. Behavioral therapy for autism, there has been a lot of debate going on about the use of various behavioral interventions. Some of them are copyrighted and trademarked interventions. Some of the interventions require specialized training. But what I personally believe is that we as OTs should not solely focus only on the behavioral aspect of a child. Rather, as we say, for all clients, there should be a holistic view of the child as well. We can work using behavioral modification techniques. We can use a variety of skill training techniques, but it is essential, or it is imperative, that we understand why a behavior is taking place, or what is the root cause of the behavior. Is the behavior purely behavioral, or is it both sensory and behavioral? So by incorporating behavioral therapy principles, we work with the clients, or we work with the children in improving specific behaviors and teaching them certain skills which are necessary for adaptive coping within the environment. We also try to reduce the maladaptive patterns of behavior by either the use of certain reinforcement strategies, or by the use of certain techniques through which the maladaptive behavior can be gradually reduced and the desired behavior or the adaptive behavior can be increased in the frequency. We also identify the reinforcers which are specific for each child. What may be reinforcing or rewarding for one child or one individual may not necessarily be rewarding and reinforcing for another. So by working actively with the client, we identify what are the reinforcers that will possibly work and then implement what we have identified in our therapy program. We also teach the parents as to how they can shape the child's behavior in the home settings. We also work proactively with teachers to help them understand what are all the behaviors that children may possibly show, why those behaviors are being exhibited in the classroom, and what are certain classroom strategies which they can implement in order to reduce the impact of a particular behavior on the entire classroom. We have different activities, we have different home program strategies which we can use for children with ASD and other neurodiverse conditions. To conclude, I want to add that medicine does add days to life. Occupational therapy adds life to days. Thank you.
Thank you so much, ma'am. That was an amazing presentation wherein you have given a complete package of role of occupational therapy in mental health. And also you have used an effective teaching method where a lot of colorful presentation made students to look at the presentation as well. So that is definitely a nice approach, because a lot of presentation will have a lot of paragraph, line by line, wherein students will not listen. But then presentation like this, students will obviously listen. The ultimate aim of the objective of the presentation is delivered to the selected or the target population. So thank you so much for that. And now I request Raghuram sir to give a note. Thank
you. Good evening, madam. So I'm really humbled to have you on today's webinar. So it's really very good start for us, because this academic year we are going to start our PG program with 4 specialties. So I think within 2-3 weeks, the official announcement will be done throughout India or worldwide. So in this occasion, so having webinar like this is really will sensitize everyone. So how important mental health is. So I hope our alumni or those who are in internship period, they will think about how important it is. Maybe they think differently, because most of the occupational therapy students are always thinking about what to handle the pediatric conditions and what to handle the neuro clients. But psychiatry is the area which even the occupational therapy is originated because of this area. So we have a lot of things to do, and I'm happy to bring to our notice, ma'am, that one of our student in 2018 batch student, he did his project I think related to prison. So for that he got permission from the commissioner of the prison, and he worked a lot, and for that our faculty helped a lot. So I think this session definitely will alert everyone to think about mental health, especially our OT students who are studying in Ramachandra. Because from this year onwards, the PG programs are there, so maybe they think about. And I feel that you are the right person. Why I'm saying that, though many seniors are in this profession, so you are you have started your career in KMCH after completing your UG, PG over there, and being a gold medalist, and you have proven again and again how efficient you are. And I think you will be the evidence for them. Okay, so thank you so much, ma'am, for your valuable presentations. So I hope, as our moderator said, everyone understood your presentations. Thank you, ma'am.
Thank you very much, sir, for this wonderful opportunity which you provided me to interact with such a lot of students and professionals. It is indeed a very humbling experience for me to talk and share my ideas with all of you. And as Sir said, maybe a few of you will take inspiration from today's presentation. Today's presentation, I tried to make it as comprehensive as I could. I can say that it is just a drop in the vast entire ocean. Our profession of occupational therapy itself is a vast entire ocean. Mental health is another ocean in itself. So I've tried to summarize everything that I could possibly in a small talk, and I hope it is helpful to all of the participants for today. Thank you.
Thank you, madam. Now the session is open for discussions. Do anyone have any questions regarding this presentation? You can switch on your mic and you can ask. Or if you want to type in the chat box, I can read it for you.
If there is any feedback that the participants want to share, I would be open to accepting feedback as well.
Sure.
Good afternoon, everyone. I am Mitra, Bachelor of Occupational Therapist alumni from Sriya. First, I would like to thank our Honorable HOD Sir and our faculties for organizing this webinar. Thank you, sir. And it is actually an important topic since everyone requires good mental health to be productive in day-to-day life. So today, ma'am have highlighted occupational therapist role and significance in mental health with her excellent presentation in detail. So this presentation from Nidhi ma'am is insightful and knowledgeable, ma'am. This supports students and practitioners in clinical aspect with your resourceful words. So it was a great presentation and we gained good valuable information from this webinar, ma'am. So for that, I would like to thank immensely for you, ma'am. So thank you, ma'am.
Thank you very much, Mitra, for the kind words of appreciation. This wouldn't have been possible without the support of the institution. Ramachandra has played a major role in organizing today's webinar so smoothly and without any glitches.
Good afternoon, ma'am. Ma'am, I'm Joanna, doing my final year. Ma'am, first of all, I would like to say that your presentation was amazing. We really enjoyed it. Like the way you explained it, like with so much clarity, it's really helpful for us. Ma'am, I have a question. Like, as occupational therapists, we always use like a holistic perspective, right? So, taking in consideration a condition like total knee replacement, they will, after like post surgery, they will also face like fear of falling, so they don't want to get back like walking. So like, can you like explain to us like how will we bring in a psychiatric perspective there to treat the patient?
Joanna, wonderful question, and I appreciate that you have recognized the psychological aspect that comes with a major surgery like total knee replacement. So, most often, what happens in clinical settings is patients are not informed about what can be the possible aspects, that they are always informed about what will be the outcomes that will be achieved as a result of a surgery or as a result of an intervention. But what comes along with that, what are the side effects that they can possibly face, how all they need to make up their mind in order to face their life after that particular intervention, is often unaddressed because of lack of professionals, because of lack of time. We do not give or impart adequate clinical information or clinical education to our clients. So before they undergo such major procedures, if we are able to psychologically shape their thinking in a way that they are better prepared for such interventions, half of their fear is lost there. They are well prepared mentally that these are the outcomes that they can expect, and these are some of the complications which they will have to face post surgery. So as occupational therapists, it is the art, or it is in our hands as to how we convey that information to a client. If the client is from a very let us say well educated background, then the client may understand in simple terminology. But if the client is from some rural background or not having adequate means of education, they may not understand. Rather, they may get more scared if we are going to explain to them that because of the surgery, you will have a higher risk of fall. So we as therapists will have to identify how we convey the information to the client. This is pre-surgery. Post-surgery also, once we work with them, we need to teach them certain strategies or certain mental exercises which they can do how they can include positive self-talk, how they can use MBSRT or mindfulness-based strategies in order to reduce their apprehensions, in order to reduce their stress level. So by looking at it from a client-centered perspective, we can help the clients irrespective of what their condition is or irrespective of what the diagnosis is. I hope I have answered your question, Joanna.
Yes, ma'am. Thank you, ma'am. Thank you, ma'am.
Thank you. Thank you.
Good afternoon, ma'am. I'm Lokavarshini, again a final year student. Your presentation was really wonderful, ma'am. So thank you very much for that. Ma'am, also I have a question. So we know patients with mental illness can get extremely aggressive at many moments. How do you think we can manage that? And what are your thoughts on us as therapists getting trained for the same, as in physically or anything for that matter?
Could you please repeat the second part of your question? Your first question was, how do we deal with clients with extreme aggression? What was the second part of your question?
Ma'am, it was like, I just wanted to know your thoughts on us as therapists, like getting trained for the same, as in like physically or anything for that matter.
Right. So psychiatric clients or clients with severe mental illnesses tend to get extremely aggressive. It is sometimes brought to our notice that the client is very aggressive, you need to be careful, or sometimes even it is shed in a negative light saying the client is extremely aggressive, don't work with them. So not working with them is something which would be rather from an exclusion perspective. We are being biased to our clients just because he or she is aggressive. Our not working with them is doing injustice, or it is something which we are depriving our clients of. We are depriving the client of our services. So medication management does have a role in extreme aggression. Once the client is stabilized or is calmed down through the use of pharmacology, it can help to reduce their aggression to a certain extent. From an OT perspective, I think if you're going to tell them that you're being aggressive and please calm down, please don't be aggressive, that's not going to work out if you're going to verbally tell them. Rather, we can channelize their aggression in a way so that they are able to express it in a safe way. We can teach them certain strategies. For example, the punching bag strategy is something which we can commonly use. The client is able to channelize their aggression by punching into a bag. If we have children who show certain aggressive tendencies, what we can do is we can channelize their energy into physically demanding activities which require a lot of energy expenditure. So by channelizing their energy into other diversional activities or other meaningful activities, we are reducing the amount of energy that will be available for them to exhibit as a part of their aggressiveness. There can be verbal aggressiveness, but the physical aggressiveness, which can cause harm to the client himself or to the therapist, will definitely be reduced if we are able to channelize their energies. I really appreciate your thought on we being specifically trained physically and mentally to handle such clients. So it is important that all of us should be trained in at least basic level of self-defense skills so that we are able to safeguard ourselves if an opportunity or if a situation like that arises.
Yes, ma'am. Thank you very much.
Thank you.
Good afternoon, ma'am. My name is Bala Abhirami, and even I'm a final year student. First of all, occupational therapy and mental health is a very, very vast topic, and putting it into such a small and precise and very crisp presentation, and you explained everything, so it was really nice to have it in such a short and sweet manner. So thank you so much for that. Ma'am, I have two questions that I want to ask you. So the first thing is about how, as occupational therapists, we can manage patients with antisocial personality or narcissistic personality disorders, because especially when you're going to see it from a forensic perspective, it can you have a lot of offenses that are happening all around the world, and when OTs actually do have a solid role in that, but we just don't know what about it. It will be really nice if you could tell us about it.
Right. So personality disorders is a topic which I consciously skipped because I am not personally advocating the use of the term personality disorder. But since we have it in our major classification systems, antisocial and narcissistic personality disorders, as you rightly pointed out, are the clients who we will encounter while we work in prison settings or forensic settings. So while working with them, we will need to understand what their psychology is, rather than the psychiatric aspect, what their psychology is. From a psychoanalytical perspective, if we are able to gain some kind of insight as to why that particular personality is stemming, or why their behaviors are in such a way as to get a diagnosis of a particular personality disorder, we will be able to identify the core as to why a client is behaving in a certain way. What are the triggers, or why is the client's way of behavior channelized in such a way? So that is one aspect, that is identifying why a particular behavior is taking place. The second aspect is working on their social skills. Now they're already outcast, or they're removed from the normal society that we are living in. So as a part of our work, we should also be working on engaging them and bringing them back into the society, what we can call as the community reintegration. They have been out of the community, out of the normal regular society, and we will have to work on bringing them back into the community. So we will need to gradually train them and expose them as to what are the acceptable social behaviors, why the behaviors that they are exhibiting are not appropriate from a societal viewpoint, and also teaching them what can be the right behaviors. So that cannot be in an approach where we teach them all of the skills in one day or tell them everything in a single day. Rather, we can use a group approach with a psychoanalytic perspective and work with the clients in improving their socialization and social skills.
Thank you so much, ma'am. Ma'am, I also have another question. So you mentioned about SI groups, and you also mentioned about reminiscence therapy and a few other techniques. But how aware are occupational therapists actually about such different kind of techniques, and how much is it being used right now?
Right, Balabirami. For a final year student to think so much into it is something which I truly appreciate. So SI groups have been in existence since a long time. Gene King's hypothesis is what shapes our thinking about SI in the use of adult psychiatric setups. As you said, not a lot of therapists are aware as to how to use those. They know what SI therapy is, but they're not really aware of how it is used for children, for adults. They are well aware of how SI therapy is used for children, but not with adults. Similarly, reminiscence therapy, apart from a few research studies, actively, though it may not be used with the term reminiscence therapy, we are using it in indirect ways, where we ask clients to recall positive life events, where we engage them in activities which they found previously meaningful. So in spite of not using the terminology such as SI therapy or reminiscence therapy, we are using certain techniques from these approaches in our clinical practice. And as you said, there is a need that we get more knowledge and more information about these techniques and implement them in our practice.
Thank you so much, ma'am.
Good evening, ma'am. Myself, Abhirami, second year student. So I have a doubt. What is the first episode and BPAD, ma'am? What will be the first episode?
You want me to explain about bipolar affective disorder or borderline bipolar affective disorder? Bipolar affective disorder can be of different types. It can have different clinical presentations. What primarily comes to notice more than depression is the hypomanic state and the manic state. So usually it doesn't start with mania as such in most cases, but starts with hypomania, where there is an increased agitation, there is increased psychomotor activity, etc. But there are two subtypes, bipolar type 1 and bipolar type 2. So depending upon the classification, the clinical presentation varies.
Thank you.
Thank you.
afternoon, ma'am. Myself, Janapriya from second year. Thank you for the wonderful presentation, ma'am. And can you tell me what was the OT management for a BPAD patient with sleep-wake disturbance?
Okay, that is an interesting combination by itself. Patients with BPAD having sleep disturbances because of acute hypomania or mania. These patients have established difficulties in initiation of sleep as well as in maintenance. So drugs are prescribed as one aspect of the treatment, but what we should work upon is on activity scheduling. From an OT perspective, we can work upon activity scheduling. We schedule their day-to-day activities in such a way so that by the end of the day, they are tired and they are able to fall into an easier sleep routine. We can also establish certain sleep routines or relaxation routines which they can implement before bedtime, and we can also teach them certain strategies which can be anxiety reducing strategies and stress management strategies. So in case they're not able to sleep, or if they have these disturbing thoughts which are preventing them from having sound sleep, they can use these strategies and have better sleep quality. And sleep hygiene education is something which we will be imparting to all of our clients, irrespective of what their diagnosis is. If a client comes to us and says that I have difficulty falling asleep, or I have difficulty in maintaining my sleep cycle, or if I have difficulty because of reduced sleep, I feel that I'm not productive the next day, what we do is we try to teach them about sleep hygiene measures. So there are various sleep hygiene measures such as having regular bedtimes, reducing the consumption of caffeine, reducing the digital screen time that we usually have, etc. So by teaching the clients certain sleep hygiene measures, they can use self-regulatory strategies, and there can also be certain environmental modifications which we can make which will enable better sleep quality.
Thank you, ma'am.
Thank you.
Good afternoon, ma'am. I'm Nancy from second year. Thank you for your informative presentation. I have a doubt. Like, what is the
Yes, please.
uniqueness of occupational therapists in using the CBT techniques from the other professionals? What is the difference, ma'am?
Right, Nancy, wonderfully put. What is the difference between OTs using CBT techniques and other professional using CBT techniques? So it has been an area of debate amongst many professionals as to how do you say as an OT that you're using CBT techniques. We are not exactly doing cognitive behavioral therapy. We are implementing the ideas which have stemmed from the cognitive behavioral perspective. That is why I use the term cognitive behavioral frame of reference. So while we use the cognitive behavioral frame of reference, other professionals might use it in a way of talk therapy, just as we have for psychoanalysis, which is more of a talk therapy. Cognitive behavioral therapy, when implemented by other professionals, can be more of a talk therapy, where they help in identifying what are the client's negative thought patterns, what are the primary schemas that they have. But as OTs, we identify, because of their cognitions, what are all the behavioral implications that are taking place. Because of their cognitions, what are all the limitations in activity participation that are taking place. And we implement strategies, we implement practical activities from a theoretical base using CBT. For example, desensitization, creation of hierarchy, all of those stem from the cognitive behavioral theory. But we implement it in such a way such that we use an activity-based approach to enable participation. I think I'm giving some clarity, but in case there are other perspectives, more than happy to welcome those perspectives.
Thank you so much, ma'am. Considering time limits, we can go to the next session. Thank you so much for your patience answering for questions. I'm happy that many of our students asking so much of questions, but yeah, all your questions will be clarified. Kindly email all your queries. Thank you. Now I would request the participants to give your feedback if they need.
Good afternoon, ma'am. Myself, Gokul A, current student council member, pursuing a final year Bachelor of Occupational Therapy in Sriya. I would like to express my regards for this extremely informative webinar. Thank you so much, ma'am, for taking your own time to share your knowledge with us. This presentation was being like a holistic kind of presentation, the way it gets started with the occupational therapy being an holistic approach as a collaborative process, and the area of concern, like we work beyond motor, sensory, cognitive, self-care, etc. And the short-term goal and the long-term goal rehabilitation, almost covering all the conditions. So being a final year student, this made us all clear about the psychiatry stream. Hopefully, this might help us in the future in choosing psychiatry as specialty. So I would like to thank our respected HODs and our faculties of occupational therapy for organizing this national webinar and making us participate in it. Thank you so much, ma'am.
Thank you. Thank you very much for the very kind words from the students.
Ma'am. Myself Shirley, I'm a final year Bachelor of Occupational Therapy student at Srihar. Firstly, I would like to express my regards for this extremely informative webinar, ma'am. It was very useful for us. It was very detailed, clear, and understandable. I really liked the part where you explained about the common conditions, the areas of OT practices, and also about the different groups in OT, like the personal care group, the creative activity group, the SI group. Thank you so much, ma'am, for spending your valued time and sharing us with your knowledge and experience with us, ma'am. I would like to express my gratitude to our respected HOD, Dr. Raghuram sir, and also I would like to thank all the faculties of Ramachandra Faculty of Occupational Therapy for organizing a very informative national webinar. Thank you, everyone.
Thank you, Gopal and Shirley, for your valuable feedback. Now I would request our Dr. Logna and Assistant Professor to deliver his vote of thanks.
Hello, yes, thank you, Yashwant. Good afternoon to one and all. It is my honor and privilege to propose a vote of thanks at this special occasion. On behalf of Sri Ramachandra Faculty of Occupational Therapy, I would like to express my heartfelt gratitude to our chief guest, Dr. KV Professor of Prevalence and Advisor of Academics, to grace this occasion and give sorry for the interruption. Yeah, I would like to express my heartfelt gratitude to our chief guest, Dr. KV Somasundaram sir, Professor Eminence and academic advisor, for his great chief guest address. I would like to extend my gratitude to our guest speaker, Dr. Nidhi.N.Dave, for sharing his elaborative knowledge on occupational therapy in mental health. Occupational therapy in mental health is very important area where the occupational therapists can practice. I want to quote at this moment one of the important information. In recent study in Tamil Nadu, states that around 10% of students, including school going students, using substance abuse recently, which is very higher in recent decades actually, and also in India, which is the highest ratio. We have to focus, we have to contribute for the society to prevent or to prevent the substance abuse spreading among the students, where we can also practice in rehabilitating the substance abuse patients. Okay, and also geriatric also one of the important area where the scope will be very brightful future, because the increasing rate of geriatric population will be doubled comparing to the 2017 survey by 2030, and also to 2050 it will be furthermore doubled actually, because increasing number of degenerative conditions. So there will be a very scope. I hope students also will enlighten this presentation. And furthermore, I would like to express my head, Professor Dr. Raghuram sir, head of Sri Ramachandra Faculty of Occupational Therapy, for his immense contribution and guidance throughout the event. And also, I would like to thank our faculties for the support And finally, I thank all the participants for their present and also their participation in the discussions, valuable discussions. I hope everyone enjoyed this presentation. Thank you once again. Thank you, Madam.
Thank you, Dr. Loganathan, sir. And I want to take an opportunity to thank all of the students who have spent a precious Saturday afternoon in listening to such a topic of relevance. And if not anything else, I hope I've been able to inspire you to look at the unique role of occupational therapy in mental health and implement some of the ideas that you have gathered today in your day-to-day practice. Thank you.
Thank you, ma'am. So I will get back to you in the evening, ma'am. Thank you.
Thank you,
Sure,
madam.
thank you.
Thank you,
Very
HOD,
much,
sir.
sir.
Thank you, Logan, sir.
Thank you
So
Dr.
much,
Vishnu,
ma'am.
sir.
A
Thank you.
big round of applause behalf of my faculty, ma'am. Thank you so much for the presentation.
Thank you to the entire team at Srihar. Thank you so much.
Thank you, Yashwant. You did your job perfectly. I think this is the first time he is moderating the webinar, and always he will do his best. And again, he proved it. Thank you, Yashwant.
Thank you so much for this opportunity, sir. Thank you very much.